The technical manager, health workforce training and regulations at the USAID-funded HRH Kenya mechanism. He has 12 years working experience in health system strengthening, focusing on HRH, governance and leadership, policy and regulation. He has also interfaced with programming in the areas of COVID, HIV, maternal and child health, and civil society strengthening. He's a certified project management professional and a PhD candidate. Dr. Janet Muriuki, unfortunately we have been told that you didn't submit your bio, so you will help us introduce yourself to the audience. So can we have our slides pushed for Dr. Janet Muriuki? Thank you very much.
Secretariat, the slides. Good afternoon, everybody. Glad to be here this afternoon to make this presentation. As the technology team is putting up the presentation, I will go ahead and introduce myself. My name is Dr. Janet Muriuki. I'm a medical doctor and a public health specialist. I've been within the health sector for close to 19 years now, supporting in different capacities, both in public, private, and also now from the development world. I've been previously the chief of party for USAID-funded HRH Kenya mechanism, and previously the technical director for the same project, but also the HRH Capacity Bridge project and Capacity Kenya project. I'm now currently serving as the country director for IntraHealth, and at the global level, the senior director, health workforce development. Thank you. Thank you very much, technical team. Yes, so this afternoon, I'll be making a presentation and accessibility of medical training to meet the needs of universal health coverage. This is my presentation outline. Next slide. So what really is the background towards the health sector's experience? I think critically, and this has been mentioned in various panel sessions, is the shortage of critical health workers due to the high cost of medical education. There are also glaring gaps between pre-service and in-service with medical education institutions, and I'm talking about here both the universities and the colleges, sometimes not producing graduates who are fit for the market. And I think that's where we are here in this conference. Curriculum may not be competency-based, it's more of the theory, and may not be responsive to both the county and national health needs and priorities. There have also been weak linkages between the clinical instructors, what they call the preceptors or the mentors, when students are actually going for placement. And this is arising because accreditation of health facilities at teaching hospitals is limited. We have more for internship than student placement during their training years. The linkage between the ministry, regulatory bodies, and medical training institutions still needs to be strengthened. A lot has been done, but I think we can do more. inadequate institutionalization of in-service training, poor training data system for real-time data to make informed decision-making, the delays in actually translating data that comes from training assessments, and various have been undertaken, but their dissemination and forward implementation of their recommendation has been a challenge towards policy formulation. And lastly, really around COVID. We needed to have done more in terms of preparing our workforce for the pandemic, not from just face-to-face training, but also ensuring we had adequate online training. So IntraHealth began its journey, the partnership with the Ministry of Health pre-devolution. This schema highlights that journey from a project known as the Global Capacity Project through to Capacity Kenya, and then at the time of devolution, USAID was able to grant us 2 projects, the Funzo Kenya project, which I'm going to focus a bit of my presentation on, and subsequently the HRH Capacity Bridge project and the HRH Kenya mechanism. And the efforts of these projects that have been implemented under IntraHealth through funding from USAID have really responded to that enabling environment, functional systems for HRH, and ensuring quality, efficient and quality service delivery. What are the objectives for me as I look at these topical issues? I think when we are looking at improving the quality of training to increase the number of health workforce, I look at them from a 3-pronged approach. That is increasing the physical number. And for us, I'll mention something here about a product we did in collaboration with the Higher Education's Loans Board, known as the AFYA Elimu Fund, which was a low interest rate product that will enable students to, at tertiary level, especially the medical training colleges, to pursue their dream career. The other is really about the quality of our pre-service training, faculty environment and curriculum, and lastly, institutionalization of in-service training at the county level. To achieve this, we applied various approaches for transformative education, and my presentation will focus on these areas based on the work and our experience as IntraHealth here in Kenya: curriculum development, the training regulatory framework, faculty development, but going a step further and actually putting in place mentorship between faculty and accreditation of student placement, training data and training systems assessment, resource mobilization to improve the infrastructure that will support increasing the health workforce, institutionalization of in-service training, innovative student financing, this is the AFYA Elimu Fund, and partnership and collaboration between the sector stakeholders for medical education, both at pre-service and in-service. Part of the work that has been done previously is when we look at a medical training institution, be it a university or a college, when you're going out there to a census for both baseline and subsequent mid-term or even end-term, there are critical issues that need to be undertaken. And this assessment is based on an approach where we look at the management up to the deans, you're looking at the VC, the educators, the faculty in the various departments, the student, how are these students being selected? Are they meeting the relevant criteria for entry? And even as they are doing their exams, are they qualifying? The curriculum that is being put in place, the infrastructure, the materials and equipment that provides that enabling learning environment, the clinical practice, that exposure, because that is where they first get their mindsets to look at standards. what are the standards by which I will be going out there to provide services? And what is that environment going to look like? And this is during the student placement years. The quality assurance measures that are being put in place by the regulators, the institutions themselves, and also the hospitals. What does that look like? And lastly, the partnership and exchanges. So when my team and I reflected on a framework for curricular governance, which we implemented and had good results, we really looked at, is that taking the context of the national health needs and priorities? And where can this be sought from? I think talking to the alumni is critical. Going there and finding out, are the alumni who have been through our products fit for the market? Do they feel that we as training institutions, and I will use the word we because I have been part of training institutions during my career, are we preparing them adequately? I'm a product of one, and I can share yes, and in some instances no, because the rest I had to build from the market by having the mentality to continue to be of a learning nature. So do the curriculum address those gaps? Then you really need to look at having in place that curriculum committee, both at the regulatory level for the core curriculum and also at the institutional level. And at the in-service level is really looking at the ministry because they guide the program standards, and really that is critical. And then now going to the pre-service, the service point. This is one of a tried and tested coordination framework around human resource development. As IntraHealth, since 2010, we have supported the Ministry of Health National HRH-ICC, and alongside that, worked at the intergovernmental level to also work with the HRH Thematic Committee and also the Chief Officers of Health. And during the term of Funzo Kenya, we would bring together, and even the HRH Kenya mechanism, would bring together the deans and the vice chancellors to meet and brainstorm, to really create a peer-to-peer environment where institutions could benchmark against each other, engage across the whole spectrum of the things I have mentioned previously, and then intersect with the county. At the county level, as an offshoot from the HRH-ICC, is really the County Technical Working Committee on that supports both management and training. And alongside that, this county-specific HRH committee, technical working group, would intersect at the cluster level where we are bringing a group of counties to engage and continue that dialogue with other sectors like the Public Service Commission, the County Public Service Board, the union leaders. They do have a voice in all this, as well as the HRH unit. So what have been the results of some of this work? I think the main important thing is the enabling environment, and those are the policies. One thing that has been anchored, especially for in-service training, is through a document that was supported, through the training policy, the training procedure manual. At the institutional levels, I'll give examples of Kenya Medical Training College. We supported the quality assurance policy, a curriculum policy, and at the same time looked at even how does one accredit clinical placement sites, give a roadmap towards that. How do we also look at continuous professional development, and policies were created towards that, and we'll demonstrate how they were implemented. On performance standards, we went ahead and engaged with the various regulators to formulate what the standards would look like for various programs, whether it be doctors, nurses, clinical officers, nutritionists, and these were in efforts to ensure that there was compliance to the standards, both global and international. And I think now is the time to actually reflect on some of these standards and to see, are they due for review? And I think the answer would be a probable yes. Continuous professional development, this is critical for our health workers who are in the labor market serving. So again, we worked with the various regulators to ensure these documents were put in place. Core curriculum, working with the doctors board, nurses, council, clinical officers, environmental health, public health. We were able to also put some of this work in place to guide the medical training institutions. Some of the results really for us over this 16-year journey has been the establishment of the curricular committee. And these curricular committees were able to actually go out there, review their various programs. 81 of these were reviewed, and as end of 2020, 22 curriculums had been approved for those that were new, but the others were within the threshold of the institutions to move forward with them. Resource mobilization committees were also put in place. Various proposals were put across, either to financiers, public, to the Treasury, the PPP unit. Others put in place strategic plans that have been able to move on and be actualized with the support of the various institutional boards. We also looked at pedagogy and andragogy for faculty. We encouraged them to go out there and also mentor others, and this was working with about 13 medical training universities and colleges, so that they could support interdepartmental, then externally inter-institutional. So a university could easily mentor a college. For example, when I look at Moi University, they were able to mentor the Moi Teaching and Referral Hospital College of Health Science. We were working with the likes of Tenwek that were also mentored by the Moi University. So this actually provides the standards. This is about the AFYA Elimu Fund. I'll not go into the details, but the outcome of this was 40,000 students supported, with those graduating and also going into the labor market. And the total pool of funds came from both government, private sector, and development partners of about 3 billion Kenyan shillings. At the end of our work, critically was looking at the maturation of the counties. Where were they? And we looked at those various building blocks, really to say, have we left sustainable systems? The answer would be yes. More could still be done, especially at the county sector, for institutionalization of in-service training. I'll skip that in interest of time. So what are the takeaways that I would want to leave here? Sorry, the slides are not moving as I want. A few more seconds. Okay. I think what I really want to leave as the take-home messages is the establishment of the curriculum committees. These are key, and as we look at transforming education within our medical training universities, this is going to be critical. Infrastructure. Are we ensuring that we have the right teaching environment? When we also look at the hospitals that our students during their pre-service years being exposed to actually are of the standards to be teaching hospital. So I think it calls for dialogue between academia and the ministry and the county governments to really ensure that we can have more of these clinical placement sites that can also support internship to gather and support the increasing number of our health workforce. Taking stock of the assessments that have been undertaken, ensuring that they are disseminated to inform policy, I think for me is key. And then lastly is centers of excellence. This will be key, and this again will be tied to the teaching hospitals. Can we ensure that if we're looking at specialty training, for example, let me take neurosurgery, that teaching hospital is dedicated, and it can be a county referral hospital where infrastructure is actually strengthened. Can it support the training of a multidisciplinary team? The doctors, the nurses, the clinical officers, the biomedical engineers, that whole team that is required to support neurosurgery. Could our Coast General Hospital that has actually done a program on COSEXA support not only the training of the doctors on cardiology, but the nurses and other staff that are required to support cardiac service, both from a physician perspective, but also a surgery perspective. The other thing is the accreditation. I think I've already mentioned a bit of that. Financing of our trainings. We've been having a lot of scholarships, but I think we need to move to the next level where there's government commitment to support a loans product. This is what is done in the US, the UK. Education of students, but we have it at the degree level. What about our diploma level? The bulk of our health workforce are our nurses, our clinical officers, health records, nutritionists. We need to support that career growth. And this is not going to be possible just through the county bursary funds, but there's need to look at a loans product beyond scholarship that will sustain their development. Another point I want to bring out as my chair sends me off is really our community health assistance training. These are the supervisors of our community volunteers. We need to support their training. Right now, we're having a mismatch in the ratio of the supervisors for community health, the extension workers, and the volunteers. Most of them are supervising up to 30 of the volunteers, yet the community health strategy advocates for a ratio of 1 to 10. But who is producing them? Our medical training colleges, apart from one, are not accredited to produce that diploma cadre. So I think there is a move towards, and in the spirit of UHC, and what we have seen around COVID, this is a cadre that needs to be supported and ensure that they look into the quality assurance of the community health services. And lastly, innovative training. Can we move beyond our classroom? E-learning, mentorship, on-the-job training is critical for the development of the health workforce. And this will also reduce absenteeism, because when people are in classes for their training, we're increasing absenteeism. Thank you very much. I will pause there. I think I have brought together my conclusions and recommendations. Thank you for your attention.
Tumupigie makofi. Thank you very much, and apologies for being a bit nasty to you because we are really chasing time. So I would like to request Dr. Sospita to take on the floor, and kind also bear with me. I'll be harassing you a bit. Thank you.
Great. Good afternoon, everyone. Good afternoon.
Good afternoon.
So as I wait for the presentation to be loaded, so it's my pleasure to be here with you today afternoon, basically to have a discussion with you for the next 20 or so minutes.
15.
On 15? 15, I'm being told, on really what needs to be done by the counties, especially on the leadership, on issues to do with training. because as you know, on issues to do with in-service training, we are really lagging behind pre-service training. For pre-service training, there's a lot of focus on curriculum development. There's a lot of focus on building the capacity of faculty. But for in-service training, not much has been done, especially in the county that have taken up the UHC model. So I'll request that we start off. Great, so my name is Sospit Andaba. I work for the USAID-funded HRH Kenya mechanism that is implemented by IntraHealth. We're actually in the same team with Dr. Janet. But my presentation will really focus on a training needs assessment that we carried out in the year 2019 in 10 counties, and the implication of this TNA, especially in decision making, ensuring that the trainings that we're implementing in the counties are really aligning to the situations on the ground. Because before we did this TNA, there was a lot of focus on the quality of training and even aligning this to the requirements, especially in terms of the competencies. So this is my presentation layout. I'll quickly move to the introduction. So a TNA is basically a process that combines two things. As we know, knowledge is compartmentalized into two. We have tacit knowledge, which is knowledge that you gain from your workplace, from your interactions, but also we have explicit knowledge that we gain in class. So a training needs assessment essentially looks at how we can bridge the gap between what we know and what we should be knowing in context of the two knowledge gaps. And a TNA essentially should be done after 2 to 3 years. And you can see this is key, especially having done this in 2019, a lot has changed between then and now. Before then, we did not have COVID-19, and also the strategy change to scale up UHC has just started now. So indeed, there's a lot of focus on what kind of knowledge and skill competencies we can have in terms of having quality healthcare that is aligning to UHC. In terms of background, training has been a national function until we had the promulgation of the Constitution in 2010, and this was now transferred to the counties. But I must say that the counties have been ill-prepared in implementing these trainings, both short course trainings, which are 6 months and below, and also long-term trainings. And this is essentially because of lack of capacity, lack of resources, and even lack of motivation and the know-how to implement the training needs assessment. And as per the MOH guideline of 2015, it critically says that, it basically emphasizes the need to have a TNA done, which is evidence-based, before any training intervention. And I think this is key in any public health intervention. You need to have something that is evidence-based that preceding this. The objectives were 3. The main objective was to establish in-service training gaps and priorities to inform implementation of universal health coverage, especially in context of coming up with training projections for each cadre of health workers and even budgets, so that the counties are able to lobby the MCAs to include these training budgets in the county work plan, but also use this as a basis to lobbying the partners to fund trainings. Specifically, we're also looking at how this can also lead to knowledge in terms of leadership and management gaps. So we're also looking at coming up with gaps also on issues, the technical issues related to service delivery. And this linking, of course, with development of the training projections and budgets that I've just alluded to. So the data collection was done in 10 counties, and the emphasis here was on buy-in from the counties. And in this regard, we had planned several workshops with the county leadership. We started off by writing a proposal to the county Minister of Health. The county Chief Officer of Health and directors were engaged, basically to have their buy-in. And this also took place in context of a CHMT workshop. This is the county health management team. We engaged them, and we had their input, especially in contextualizing the data collection tools. We formed a smaller committee after that meeting to lead the process of data collection after the customization of the tools. And we also had a piloting done in each county for us to understand which areas we need to prioritize. Data collection took a whole month. We had purpose to do this in 2 weeks, but there was a lot of delay, especially in receiving feedback. Because we are moving from hospitals to hospital, we're also moving to the sub-county health management teams. And as you know, some of these counties are quite huge, so the movement was also delayed. So data collection took a bit of time. After the collection, we did analysis, and we did this using Excel and SPSS. And after that, we had to have dissemination and validation workshops. And this was key for us. As I said before, we needed the buy-in and also the input of the counties. And of course, this was followed up by key recommendations, which we're going to discuss shortly. So the 2 photos show the process that we used in data collection, the discussions we had with the county leaderships. The first one is a discussion, data collection discussion with a medical superintendent, and the second one is a CHMT focus group discussion. As alluded to earlier, the counties that we focused were 10 as outlined, and the sampling was purposive. We used a 3-pronged approach. We had data collection done from the top leadership, the CEC, and the Chief Officer of Health, and the county directors. But for us, the key decision makers were the CHMT, the sub-county health management teams, and the hospital management teams from level 4 and 5. And for quality purposes, and for that third eye, we roped in the partners just to give us some insights from their perspective. We used several data collection tools. We used questionnaires, structured questionnaires for the top leadership. We embarked on focus group discussions, especially in the hospital setup, where we engaged them through their weekly CMEs to collect the data, and even also used desk reviews with the HRD department to get insights on what has been done before. For data analysis, we use a triangulation approach from the 3 data collection tools for us to get the key areas, the priority areas of focus in terms of the training gaps that we identified. So quickly to the findings. This diagram basically shows the respondent distribution, and as you can see, majority of the respondents were from the sub-county and the county health management teams, because these essentially are the decision makers on the ground. We also had level 4 and 5 hospitals, and the smaller numbers were represented by the top leadership, as indicated. So this diagram basically shows the key findings, and if I can quickly explain, the x-axis shows the respondents, the distribution of the respondents in terms of the numbers on, who prioritize the trainings. The y-axis, we have the service delivery domains, and in brackets, we have included now the key priority training areas that we identified. So I can quickly take you through this. For the TB HIV service delivery domain, we found that the key training priority was pediatric TB management. For public health service delivery, we found disease outbreak, preparedness and response taking the lead. For nutrition, we had maternal, infant, and young child feeding. For rehabilitative services, we had speech and hearing therapy, and this came out often from these counties that indeed they need to engage this group, disadvantaged group. For nursing, we had immunization, and the plan going forward is to unpack this to know which aspects of immunization that we can really emphasize on. For pharmacy, we had drug supply, management, policies and guidelines. Health information, we had data analytics and training. For radiology, we had CT scan, and especially this is in regard to the government system of procuring this through the SME procurement. And so this has to do with a lot of radiology and management of this machinery. Laboratory services, we had quality management systems. Reproductive service, we had emergency obstetric and neonatal care. Clinical services, we had integrated management of childhood illnesses. And finally, malaria services, we had malaria case management. So these were identified as the top or the priority disease, the priority training needs for these counties. We had many others that we have not included. We have just included the top priorities. For LMG, which was quite key for us, apart from looking at the technical aspects of service delivery. We are looking at also issues of performance and issues of career progression. So what came out in terms of performance was leadership for service delivery as a key need. And for career progression, we had senior management course. And as you know, many of these courses are offered by Kenya School of Government. So for discussion, I think from our initial interaction with the county, we found that there's really a huge unmet need for training. And this is specifically because many counties prioritize the training of only 3 cadres. In fact, we ended up calling them the cartel of trainees, unfortunately. And these are the medics, the nurses, and the clinical officers. So there's a lot of demotivation on the ground from other cadres because they're not really engaged in training opportunities, both long-term and short-term. And one of the consequences we have found of this is that there's poor service delivery because, of course, there's a lack of these competence and skill sets that are required for quality service delivery. There's also demotivation, as I've outlined, especially where they seem to have a lot of favoritism in terms of the cadres that are being trained. And finally, there's attrition. There are many cases of health workers who have left government service to move to other institutions, especially academia. We have an influx of health service workers moving to academia because of career progression. So prior to this exercise, we also found that the counties were using different methods of decision-making in terms of training. Key amongst this was benchmarking, which is really not scientific. You'll find County A benchmarking with County B and using their training gaps to train the health workers. And this is very rampant with the counties. We also found that many of these trainings are also partner-led. And as we know, many partners have their own agenda. So you'll find that in many counties, there are repetitive trainees or repetitive trainings. And these trainings are really not aligning to the situations on the ground. Finally, you'll find that many trainings in the counties are aligned to health worker needs and aspirations, which really should take second slot. The first should be the county needs. So finally, we're saying that the training needs assessment should really be a basis for the counties to know what kind of resources they can invest in terms of training, because it's evidence-based, it is people-led, and there's a lot of buy-in from the health workers, as you have seen, in terms of the key capacity gaps that exist in each cadre. So we are proposing going forward for all counties to embrace TNA. This is as outlined from the national training policy, that each county should embark on a TNA at least once in 3 years. One of the recommendations we're also coming up with, and this has been pointed out, is institutionalization of mentorship on the job training. And in IntraHealth, we have identified mentors and champions in each cadre to embark on the job trainings, and even e-learning, because there are many online resources that we can use for this. Thirdly, we need to engage with partners and MTIs. I can use the example of Kilifi. They have an MOU with Pwani University, and they're implementing trainings. The last time I was there, they were implementing a training on monitoring and evaluation. Those key partnerships are important, especially right now we are looking at many counties having their own universities and training institutions. Those synergies are important. Finally, we have come to realize that partners are also to blame. Many of the trainings that are implemented by partners are not evidence-based, and they're repetitive. And this leads to a situation where we have what we call professional trainees. And when you go to these countries, you find many of them because of the per diem and other amenities that they get from these trainings. So as I conclude, what needs to be done for the counties to institutionalize in-service training? I'll just quickly take you through that diagram. It's a diagram that shows the milestones, what we call the in-service training maturation, starting with the lowest level, which is the smallest dot, to the highest, which is the red dot. So for starters, all the counties require a training committee. They require governance structures to be put in place. And these governance structures are important because the training committee is what plans and implements the TNA. The training committee is what approves training requests. And this training committee is also what aligns the stakeholders and partners to the priority trainings. So those governance structures are important. Secondly, implementation of the training needs assessment, and going further from the training needs assessment to come up with training projections and budgets. Once again, as I said before, these budgets are important to lobby partners to fill in that gap, and also to lobby the county assemblies to include this in their annual plan. Thirdly, there is need of a system for approval of trainings. We have found that in some counties, this is haphazardly done, where there is not really a defined way of getting training requests approved. So we want the counties, or we propose to the counties to standardize this process for even motivation and also buy-in, and also having a system that is applied by all equally. Fourthly is to have a data management system. In IntraHealth, we're implementing integrated human resource information system, which is a platform that enables us to understand and appreciate the role of training in the counties, especially who have been trained, which trainings they have attended, when they are coming back for long-term trainings, so that you can easily manage the trainees and even the training outcomes. Also, issues of CPDs are important. And finally, to emphasize on the last dot, which is the icing in the cake, we need to strengthen the bonding system, especially for long-term trainees. Many counties are suffering from long-term trainees who have gone for training, they come back, they have not been bonded, and they go back to do locums. And you can imagine you're paying them 80% of their salary, they have left for 4 years, but you cannot get them back. So our proposal is to have the bonding forms being signed prior to release of these health workers, so that the counties are able to get return on investment on these trainings. So as I conclude, those are the key references. I wish to acknowledge our donors, you said, for funding this process, the county that we have worked in, 10 of them. So there's still an opportunity for us to continue this work in other counties. The Ministry of Health, IntraHealth, and indeed, of course, the CHMTs and the partners who are involved in this. So thank you so much.
Thank you so much, Dr. Ndaba. Let's give him a lot of applause. He has actually made his presentation within 15 minutes exactly. Let's have the next presentation, please, such that we reserve more time for questions. We are having the next presenter online on the topic adaptations in ECFMG certification in the age of COVID-19. I think in the morning we talked about continuous quality improvement, and as part of keeping our health professionals on their toes, we realized that it's probably high time we introduced not only the continuous professional development courses or the CMEs, but we rather see whether we can actually introduce certification and recertification exams in our respective collegial systems or societies, such that we keep sharpening our minds. Let's have the next presentation. It's a recorded presentation from Jill of ECFMG. Thank you. We tried to utilize our time optimally, such that we get some time from the audience, because this is supposed to be an interactive session as opposed to a one-way discussion. So we are trying to be in time to ensure that you get a lot of relative some time to ask questions. Because we had some revolts in the morning, people are saying that they put up their hands and we don't allow them to contribute or ask questions. So we want to be as democratic as much as we can. Can we have the presentation, please? The IT team.
Medical graduates, or ECFMJ. In this role, I oversee the operations of ECFMG's domestic and international services, including our program of certification and our credentials verification service. Thank you for having me. I'm delighted to be invited to connect with you today as you explore how to position today's healthcare workforce to be the healthcare workforce we need for tomorrow. Over the past few years, we at ECFMG have had to do just that, evaluate how to support today's international medical graduates and adapt our processes and frameworks to support them to move forward and practice in the healthcare system of tomorrow. Today, I'll share with you a little bit more about our work and how ECFMG adjusted to the impacts of COVID-19 while maintaining the integrity of the certification process, supporting IMGs entering the U.S. workforce. First, a quick overview of the session's agenda. I will start by providing you with some background on ECFMG, a brief history, and a highlight of our programs and services. Then, I'll explore details of our program for ECFMG certification, reviewing the pre-pandemic requirements and the impact of the COVID-19 pandemic on our certification program. Finally, I'll end our session highlighting some key takeaways and lessons learned. ECFMG and the Foundation for Advancement of International Medical Education and Research, or FAMER, are integrated, nonprofit, non-governmental organizations. We are based in Philadelphia, Pennsylvania in the United States, but we have a global reach. Through our more than 65 years of service, we have developed core expertise on the world's medical education systems and their graduates, the authenticity of physician credentials, the assessment of physicians, research on physician migration and the U.S. physician workforce, and U.S. immigration policy impacting international medical graduates. Now that you know a little bit more about who we are, I'm going to review for you some of the key programs and services we provide. During and after World War II, the United States began to see an influx of immigrants, including many physicians who wanted to practice their profession in their new home. However, because of the varied educational systems around the world, it was challenging to determine if these physicians met minimum standards to enter graduate medical education in the United States. Thus, ECFMG was founded in 1956 with the charge of assessing through a program of certification whether international medical graduates, or IMGs, are ready to enter U.S. graduate medical education programs. This remains one of ECFMG's core functions today and is an integral part of the medical training and licensure process for IMGs. Over the years, we have expanded on this mission to provide several other services for the medical community, including support for IMGs applying for U.S. graduate medical education programs through what we refer to as the match, visa sponsorship for foreign national physicians participating in graduate medical education programs, and verification of ECFMG certificates for organizations that rely on ECFMG certification as part of their evaluation of physicians. Internationally, we support regulators and other entities around the world by verifying credentials related to a physician's medical education, training, and licensure. These are just some of the highlights of the many services we provide. As we are here today to talk about the impact of COVID-19 on ECFMG certification, I'm going to spend a few minutes now talking about what that means. ECFMG certification is the gateway to the U.S. healthcare system for IMGs. Since 1956, we have certified more than 420,000 physicians, and today approximately 25% of the U.S. physician workforce are IMGs. ECFMG certification is required for IMGs to participate in U.S. graduate medical education programs, or GME. It is also a requirement for IMGs to take Step 3 of the United States Medical Licensing Examination, or USMLE, and for medical licensure. The program of ECFMG certification has operated continuously for nearly 70 years. ECFMG sets certification requirements and determines which exams meet our examination requirements. Over the years, these have evolved, but we have always required demonstration of clinical skills and English language proficiency as part of the program. This point will become important in a few minutes when we talk about the impact of COVID-19. To start our overview of the requirements for certification, I'll start by defining who is an IMG. An IMG is a physician who received their basic medical degree from a medical school located outside of the United States and Canada. It is the location of the medical school, not the citizenship of the physician, that determines whether the graduate is an IMG. To understand the impacts of COVID-19, it's also important to understand ECFMG certification requirements prior to the pandemic. First, IMGs must meet general eligibility requirements. IMGs who meet those requirements are able to move forward with the certification process, fulfilling the requirements for certification. Once all of these have been met, the IMG can be ECFMG certified. And this framework did not change with the pandemic. Some of the components of the requirements did, but the certification framework itself remained intact. In terms of general eligibility requirements, there are both medical school and individual prerequisite requirements that an IMG must meet in order to pursue ECFMG certification. First, the IMG's medical school must meet ECFMG's eligibility requirements, including that it is recognized by the country in which the school is located and that graduates of the school are licensable in that country. In order to determine if their school meets our requirements, applicants must check the World Directory of Medical Schools. Their school must be listed in the World Directory with a note indicating that the school's graduates are eligible to apply for certification. The physician must have received from that school the appropriate degree that leads to the practice of medicine in that country. There are also education requirements that the individual must meet, including length of curriculum attended and restrictions on credits transferred to their school of graduation. IMGs also must grow through ECFMG's robust identity verification process. If the IMG meets these requirements, they can proceed with certification. There are 4 components to certification that must be met: medical science examinations, clinical skills assessment, communication skills assessment, including English language proficiency, and medical education credentials. Currently, to meet the medical science requirements, applicants must take and pass Step 1 and Step 2 clinical knowledge, or CK, of the USMLE. To meet the medical education credentials requirements, all IMGs must submit their final medical diploma and transcript, and these must be verified directly by authorized officials at their schools. Prior to the COVID-19 pandemic, passing performance on Step 2 clinical skills, or CS, of the USMLE met both the clinical skills and communication skills requirements for ECFMG certification. This had been the case since the early 2000s, and this is what brings us to 2020. In March of 2020, the USMLE program temporarily suspended administration of the Step 2 CS exam due to the COVID-19 pandemic. In May of 2020, the USMLE made the determination that the suspension would last for 12 to 18 months. The impact of this suspension for ECFMG certification was profound. Thousands of IMGs who are intending to apply for graduate medical education program positions beginning in 2021 would have no way to meet the clinical and communication skills for ECFMG certification. ECFMG quickly evolved to develop, plan, and implement a solution, the pathways, in just over 3 months. In January 2021, when USMLE announced the discontinuation of the exam, we quickly evolved again, announcing that we would continue and expand the pathways for training positions beginning in 2022 as well. This expansion launched in August of 2021. In developing and subsequently expanding the pathways, we kept several goals in mind. First and foremost is that we needed to ensure ECFMG certification continued to serve its critical functions. Certification assures the U.S. public and graduate medical education programs that IMGs are ready to enter supervised clinical training. It is a core requirement for IMGs to apply for and begin graduate medical education programs. So we needed to ensure that there would be a qualified pool of IMGs to enter training programs in 2021. In developing the pathways, we needed to maintain rigor and integrity by using appropriate measures of clinical and communication skills. We also needed to leverage existing measures available now for IMGs applying for the 2021 and 2022 positions. As I mentioned, this initially all happened in just under 3 months. in June of 2020, we announced that development of the pathways was underway, and it launched at the beginning of September 2020. Effective at that time, IMGs were able to meet the clinical skills requirement through either a passing performance on Step 2 CS or by completing a pathway. IMGs were able to meet the communication skills requirement either through a passing performance on Step 2 CS or through part of the pathways, which is the Occupational English Test, or OET, medicine exam. There are three main components to the pathways: the pathways themselves, the assessment of communication skills, including English language proficiency, and the expiration of certificates. I'll speak to each of these in a little more detail. Currently, there are 6 pathways. Pathways 1 through 5 were developed in 2020 for training positions beginning in the 2021 academic year. Pathway 6 was added for the 2022 academic year to provide an opportunity for IMGs who are unable to meet the requirements for Pathways 1 through 5. This gives all IMGs who would have otherwise been eligible for certification an opportunity to be certified. Now, Pathway 1 is for IMGs who are already practicing medicine in another country. These are mostly non-US citizens. Pathway 2 is quite small, but allows IMGs to use passing performance on OSCEs offered for medical licensure in other countries, such as Canada and the United Kingdom, to meet the clinical skills requirement. Pathways 3, 4, and 5 are primarily for students or very recent medical school graduates who have not yet obtained a license to practice medicine. All 3 pathways require the medical school meet certain eligibility requirements, such as accreditation by WIFBE recognized accreditor. They also require medical school officials to attest to the students' clinical skills. As part of this attestation, the students' clinical skills must be assessed by appropriate medical school faculty during in-person encounters. Pathway 6 is intended for those individuals who do not meet the requirements for Pathways 1 through 5 and/or who have previously failed the USMLE Step 2 CS exam. To meet the requirements for Pathway 6, the applicant's clinical skills must be evaluated by licensed physicians using ECFMG's Mini Clinical Evaluation Exercise, or Mini CEX. The Mini CEX is a well-studied workplace-based assessment tool used to evaluate an individual's clinical skills in a variety of clinical settings. Through Pathway 6, physician evaluators assess the IMG's clinical skills during real, in-person patient encounters. Completion of the pathways also requires assessment of communication skills, including English language proficiency. This is required for all IMGs, regardless of citizenship, native language, or medical school language of instruction. For this requirement, ECFMG selected the Occupational English Test, or OET, medicine exam. This exam is used for the purposes of medical licensure in countries such as Australia and the United Kingdom. The assessment includes 4 components: reading, listening, speaking, and writing, and ECFMG requires a minimum score of 350 on each component. To ensure currency of communication skills, the assessment must have been taken on or after July 1, 2018. Finally, ECFMG certificates may now be subject to expiration. Certificates issued to individuals who meet the clinical and communication skills through one of the pathways are subject to expiration if they do not begin an accredited U.S. graduate medical education program before the expiration of their certificate. This ensures reasonable currency of clinical and communication skills at the time of entry to training. Once the IMG completes the first year of their training program, their certificate will no longer be subject to expiration. This requirement provides an additional measure to assure the public and regulatory authorities that those obtaining certificates through these pathways have been appropriately vetted. If the IMG does not enter a training program before the certificate expires and wishes to revalidate their certificate, they will be required to meet additional clinical and communication skills requirements. This highlights that we are not yet done evolving our processes. We are currently working to develop the revalidation process for impacted IMGs.
Thank you very much for anyone that is interested in the ECFMG FEMA certification through the USMLEs, we actually have a working protocol on behalf of AMCO and the ECFMG. The Health Professions Council of South Africa has already actually started implementing that one. So we agreed in principle to share their database. So if anybody is interested, I think the initial steps have been highlighted. Most of our regulatory authorities are in touch with ECFMG and FEMA. So I saw quite a number of young doctors here. So if there is anyone that is interested, and particularly for the implementation of workforce migration, looking for greener pastures, though we note that we probably need to create more greener pastures here than there. But again, one can go for knowledge. You acquire as much knowledge from that side, then come back and practice in your country. So, dear ladies and gentlemen, we would like to thank our presenters, and I would like to appreciate each and everyone through a round of applause. If you don't mind, please, let's applaud our presenters. And this is a session for the Q&A, or complimentary statements, questions, or particularly where we were rushing our presenters. Unfortunately, chasing time is not easy. So if there is any complimentary statement or differing opinion or asking on the methodologies that are being used, and maybe for those that do not come from Kenya, you can compare your counties as small countries to some extent. I think they have got some degree of autonomy and all that. Where they do, I mean, where we have decentralized entities or decentralized governments, we actually have a few federated governments on the continent as well. So the floor is open. We have a microphone there and a microphone here, and I think we have also some roving microphones. We have about 10 minutes. Please make your statement short and brief and be to the point. Thank you, sir. Walk faster, go to the mic, ask your question. I think it is important for people to move than remaining still. Thank you.
Thank you, Mr. Chairman. I just want to seek a small clarification from the presentation that touched on devolved government in Kenya. Among the questions during the TNA, I didn't see the participants raise issues about governance. And I believe leadership and governance is one of the 8 pillars in health systems management. Thank you.
Thank you very much. Yes, please. Please tell us your name and indicate who you're asking. Thank you. That's okay. The question was clear enough.
Good afternoon. My name is George Rai. My question is to all the presenters. The first one was particularly on training needs assessment. I see there was overemphasis on government employment and government health institutions, yet a sizable proportion of health workers are in the private sector in the whole of this country. How do you extrapolate this issue, and how do we involve all other health workers who are not necessarily in government? The second one is it possible to make contact with clients in postgraduate environments to be part of the training programs? What I mean here that after registering all practitioners in both private and public, the very fact, and it depends on how you design it, the very fact that you have had an encounter with a patient, you need to do detailed documentation and carry out citations of that case, whether it is surgery or whether it is a medical case, so that we move on in the future to make all places a training ground. Because if we did a cesarean section in a small hospital somewhere, then, and we have systems of monitoring that, it should go into your credit for training.
Thank you, sir. Yes, please. And we need ladies as well. Let's not have gender bias in terms of giving ideas. Yes, please.
Yes, my name is Neoli Kashorda from Kenya Education Network.
If you can remove your mask, please. You are alone,
Yes.
so you...
I'm not...
and take away your...
Sorry?
Yes, please, go ahead.
Yeah, my name is Meoli Kashorda from Kenya Education Network. We are the National Research and Education Network of Kenya.
Sir, we can't hear you. Maybe I know there is a vertical challenge here. Just get the mic out of it and then talk.
Yes,
Yes.
yes, my name is Meoli, you can hear now. Meoli Kashorda from Kenya Education Network, the National Research and Education Network of Kenya. I want to ask the question, I think it was for both of them, asking the question that we have professional trainees because training is seen as a source of additional revenue. How do we solve that problem? If the training is not to help, but it is actually to increase revenue, how are we going to solve that problem?
Thank you very much. Let's first answer these questions. If there is anyone that is from outside Kenya that wants to ask, we can have that positive discrimination. If there is none, please let's answer the questions. Thank you.
Okay, so thank you for those questions. I'll start with the first one, which was on the LMG. Yeah, indeed, leadership and management training gaps were the key focus for us as we're implementing the TNA. We did not want only to dwell on the technical aspects of service delivery per cadre. We went further to look at leadership, management and governance. As you know, leadership is about decision making, and especially right now as we're scaling up UHC, we need to have more decision makers, especially in the decentralized units. So for those who are not from Kenya, just to give you insights that our health sector is devolved to the counties. They have progressively taken up more responsibilities. Some of these responsibilities were supposed to be left to the ministry, but this has been taken up by the counties. And in essence, decision making, especially on service delivery, on human resources for health, and even analyzing the successes of the interventions now really lies on the counties. So from our trainees assessment, what came out as a key gap was on leadership, senior leadership, leadership management and governance in context of performance was a course on senior leadership and governance, which luckily for us, this is a course that is being implemented by the Kenya School of Government. So our plan is to link up these counties to these training opportunities at KSG. The second one on the TNA on issues of private sector engagement and NGO, indeed, this is one of the lessons learned for us, as we alluded to earlier. This is the first time we are doing this, so there are quite a number of lessons we learned, especially on also engaging level 2 and 3 service delivery units in the TNA. For us, we engaged level 4 and 5 and also the county leadership. I think going forward, and there's an opportunity now for TNA to be done, is to engage even the private sector and the NGOs. We are cognizant of the fact that in some counties, they account to 30 to 50% of service delivery. So that is a lesson learned for future TNA. Finally, the issue of professional trainees has been a headache. This has been a headache in many counties. And this can be dealt with by different strategies. One of them is actually the TNA itself. By implementing a TNA, you're able to know the various gaps that exist for each cadre. So this locks out any trainee who does not fit into this training, especially if they are not implementing this as part of their service delivery. Secondly, the institutionalization of a database, and I talked about this. We are currently implementing a database known as Integrated Human Resource Information a system, IRIS Train, which really gives us an idea on who has been trained, when they have been trained, which area of training, and when they are coming back. And the implication of this is that, and this is according to the MOH training policy, is that these trainees should not be released for another long-term training until the expiry of 3 years. So this database is key, especially in streamlining that aspect. Finally, stakeholder coordination. We take cognizance of the fact that stakeholders are to blame for health workers missing their duties. So this is a role that we are really emphasizing the training committees to take up, the issue of stakeholder coordination, especially partners. So whatever they are training should be aligned to the TNA, and also there should not be repeat trainees, so that this aligning and ensuring that the training really meets the demands on the ground is very key. So these are the strategies I would think of, or how to deal with professional trainees. But I must admit this is a challenge that is currently existing in counties. If you do an audit, really be shocked. There'll be quite a number of health workers, especially the 3 cadres that I talked about, who really attend all the trainings that exist because of the per diem and other issues that come with trainings.
Thank you very much. 1 minute to go. Thank you. No more questions, please. Thank you very much. You can ask actually in the preceding discussions. So they are still here. So you can, okay, please take over. Dr. Ojuko will have to bear with us. We don't need blood to flow here.
Okay,
please.
Thank you very much. So I want to appreciate the presenters. I want to limit, my name is Wycliffe Ogenya. I represent Community Health Services and Development Officers Association, CHESOA. And my question goes to the first presenter, Dr. Murioki. One, what is the role of professional associations when it comes to issues of training, especially within the HRH? And I also wanted, because during the presentation it was highlighted well, the cadres, the regulators that you are working with are the mainstream regulators. And bear in mind in Kenya, out of the 42 healthcare cadres, only 9 are regulated. So what about the 33 other cadres? Then in terms of community health worker program, it is the WHO has actually recommended that the 3 main things: capacity building, supervision, remuneration. So in terms of capacity building, what is the HRH mechanism doing to ensure that the community health worker programs, they are capacity built? I mean, capacity building of that cadre. So then the other issue has got to do with, personally, I'm a beneficiary of one of your trainings, which is the workload indicator for staffing needs. I attended, but the unfortunate situation is that cadres that are not needed in training end up finding themselves. They become the professional trainees. So can we have a mechanism whereby if you need a nurse, let the nurse go for the training, as opposed to when you need a community health assistant, then you find a nurse, you find a doctor, you find a public health officer. So those are some of the issues, and I think it would be good if you look into it keenly, especially for the community health worker programs. Thank you.
Thank you very much, sir.
Yes, thank you very much for the questions. I'd like to begin by responding that the work that my colleague also Sospita has showcased on training needs assessment, this work county specific. I think this is a time right now that we need to look at training needs assessment from a national level. And the last one that was done under a prior project under IntraHealth was, that was Funzo Kenya did this, was in 2017. So this country right now is ripe for a training needs assessment that can cut across public, private, and the faith-based sector, so that there's prioritization the trainings, and resources then allocated appropriately through budgets and projections. To the question that was asked on the role of the health professional associations, they are key stakeholders in training, and to me, both to inform pre-service, and as we're looking at curricula, you have the experience of your association members. When I was talking about post-alumni survey, the associations, you bring the alumni together, be engaged, support the surveys. Are your cadres fit for the market? What was lacking at their pre-service level? What do we need to do through medical training institutions to have incorporated so that they are relevant and current to the current evolving aspects of their in the labor market? I think the other point on health professional associations is on continuous professional development. This is where you have a big role. Do you have any programs that your cadres can add continuous professional development points, even if you're not supporting their relicensure? I think this is key. Encourage them to continue learning because things are changing. Health today, health tomorrow is different. We didn't anticipate COVID. So what was done around COVID? What will be done around other epidemics, non-communicable diseases? So health professional associations do have a role in in-service training towards keeping the workforce relevant, but also towards relicensure. Yes, I do want to acknowledge that here in Kenya, we only have eight the Ministry of Health and the Public Service Commission. And for the community health assistance, there has been a scheme of service that has been put together. And that scheme of service does guide how those we are calling assistants from 3 all the way to 1 to the officers will continue progressing. So what have we done as IntraHealth? We worked with the Kenya Medical Training College to support both the pre-service and the in-service to be relevant, and especially during this period of COVID. We have trained it's a 5-month face with online for community health extension workers, and this happened pre-COVID, and even during COVID we continued to push for those supervisors, volunteers. I know there are other partners who have worked on the aspect of supervision. I would name one like LVCT or Living Goods. We collaborate with them. At the global level, we are continuing to support advocacy through, in IntraHealth, we have an arm known as the Frontline Health Workers Coalition that is advocating for adequate remuneration of our community health volunteers, and in line with the bills that are being passed currently at both the national and the county level. So we will continue supporting community health work, and we're interested in, and we have partnered on registries for numeration.
Thank you very much.
Documentation of the community health workers.
Thank you very much, Dr. Muriuki and Dr. Ndaba. Can you please give us a lot of applause? And as we go off the days, we would like to call upon Dr. Daniel Ojuka to come and share the next session. Thank you very much for listening and for asking questions, for the contributions. God bless you.
Thank you, Prof, for sharing that session ably. The next session, my name is Daniel Ojuka. I will be chairing this particular session. This session will have 3 speakers. Dr. Wangare Waweru Sika, if you could come to the stage, and Dr. Geoffrey Goboka, Thade Vuguziga, and colleagues, and then Dr. James Mwanza and Dr. Azza Bara. I think those are the presentations that are there for this session. As they come, the sessions is about two very interesting, Dr. Wangari, Dr. Azza, come. So Dr. Godfrey will be talking to us on issues of certification of death.
Right, exactly. The title is this one. Introducing ICT. Correct? So we should have the mask on. I forgot my mask on. Where are they? Where are they? Yeah. It's in my room.
Unfortunately, we don't have Wangari Sika with us. And so we will have Geoffrey go first, and then Azza. And this session is about how, as practitioners, we certify people who have died. I think it's a skill that is required in our part of the world, because mortality statistics is an important statistics in health and health management. And so we will be having an experience from Rwanda, and then our colleague, Dr. Azza, James Mwanza, and the two other colleagues will be talking to us on the ICD compliant medical certification for causes of death developed by the WHO for Sub-Saharan Africa. So let's welcome Geoffrey Goboka.
Thank you very much, Chair. So let's introduce myself. I'm Vuguziga Thade. I'm the Registrar of Rwanda Medical and Dental Council, and the work has been developed jointly with Dr. Godfrey Ngoboka. Can you get the presentation, please? Okay. Thank you very much, Chair. It's about to share a success story of MCSOD certification in Rwanda. But this success is a joint effort. There is two key persons behind this success, mainly this great man, Ngoboka Godfrey, who is the country representative of Bloomberg Data for Health. Ngoboka, please can you say hello to the team? Thank you very much. So our sister council's representative, mainly registrar, should get the contact of this man together with the people from Bloomberg Data for Health. So it is about this success for improving deaf certification among Rwandan physicians. Does it go? Can you help to see how to get to the next slide? Okay. Thank you very much. So normally, Vuguziga. Vuguziga means talk briefly. I will use 10 minutes so that you have time to ask questions. So deaf certification is correct information on the cause of death to establish the facts of death legally. And correct filling of the death certificate is a duty of a medical practitioner who is fully registered and licensed according to country regulation. So those information recorded in the health certificate is used to compare mortality statistics for better planning and resource allocation because those data inform on where to provide appropriate intervention. Let's go to the next slide. So as you can see, this is a sample of WHO MCCOD form and death certification, whereby we start from those number by C, where you state underlying cause of death. Then the second one is the intermediate death in B, which is caused by the terminal cause of death in A. So this has been the standardized form by WHO, so that our physician has been improving their skills for using this certificate. Next, please, if one can help. So, historically, before 2017, the medical doctors in Rwanda had not been trained on the certifying cause of death according to international standards. And this WHO international standard, death certificate, was not used in health facility, and the quality of cause of death was very poor. Thirdly, so the cause of death was characterized by ill-defined causes with little utility for public health decision-making. That was the key problems. To address it, we went through two approach. The approach number one was pre-service for those medical students who are at school, and then those who are in service, who are licensed to practice independently. So from the benchmark of EAC core curriculum, we have the Rwanda Medical Dental Council developed a core curriculum whereby as a benchmark for new and existing medical school. And then that core curriculum incorporated the MCCOD course units for those medical students to run it when they're at school. That's the catch them young approach. Secondly, those lecturers have been also trained on MCCOD to deliver the curriculum. Thirdly, there was now the MCCOD was integrated into clinical assessment of a digital logbook for medical intern during their internship, so that when they graduate, they are able to appropriately fill the MCCOD certificate. For in service, those who are already in service, medical doctors, there has been cascade face-to-face training program.
whereby a pool of trainers has been selected, and then they've been trained by master trainer, and then they go to train in the local hospitals during their formal or routine CPD program. Thirdly, for sustainability and to make it these courses is sustainable, with the Rwanda Medical and Dental Council, in collaboration with the Ministry of Health, HRH program, supported by Bloomberg Data for Health, have developed a robust e-learning platform whereby that MCCOD course was considered for every year license renewal. So physician should present or submit a certificate of completion of that course for as a requirement for license renewal. It was 50% of the required total CPD credit. Then number three, there was integrated MCCD into CRV system for routine death registration. Then at the end, there was establishment of a functional coordination structure from central to hospital level. For example, there is a national mortality committee in charge of monitoring this process to ensure that the system was well put in place is sustained for a long time. Next, please. Okay. Now, what has been achieved as a result? Ministry of Health issued a ministerial instruction to all health facilities to start using the standardized MCCD death certificate since January. This is a political support. Then, when we tried to do a survey, it has been shown that 98% of health facilities adopted and report cause of death using the WHO guideline. And 90% of medical practitioners registered by Rwanda Medical and Dental Council completed successfully the MCCD e-learning course to earn the required CPD credit for licensure. Then, the quality of cause of death has significantly improved from 48% in 2018 to 85% in 2021. And as a result, we have 3 medical schools. 2 are new and 1 was in existence. And then all those medical schools has incorporated the MCCD into their curriculum, and MCCD is taught in all medical schools back home in Rwanda. And then MCCD certificate was also incorporated into grading of medical doctors policy, because among other requirements, which means portfolio and patient outcome, it was also requested for them, for being promoted, they should also enroll into that course, so that we got the real data. 5, okay. And then, as the results, it was produced annual vital statistics reports with cause of death, which is issued for the public health planning purpose, and the monitoring program was also considered. Then, as the results, integrated the MCCD into CRV system for routine death certification is now done perfectly. And the functional structure from central to hospital level was established and is functional, and they have their terms of reference and schedule of their meeting to monitor the progress. Next, please. So as conclusion, the integration of MCCD into medical regulatory authorities like Kenya Medical and Dental Council, Rwanda Medical and Dental Council, is very important to implement the MCCD into in terms of quality improvement, buy-in, sustainability, and accessibility. But stakeholders' engagement is very key, and the coordination structure plays a critical role to the success of MCCOD implementation. For the stakeholder which has been working together, which we acknowledge, it's the Rwanda Ministry of Health has been very supportive. Bloomberg Data for Health, which who are going to present in the next panel, they have been very, very supportive financially and technically. We recognize them. And the new and existing medical school, especially deans of University of Rwanda Medical School and the other private one, we acknowledge them, and we could not achieve this without the support of the board member of the council and the beneficiaries, which are medical doctors. I thank you very much, Chair.
Thank you, Dr. Thade, for that good presentation. I hope that we will have one question for Dr. Thade. But before we get to the questions, Dr. Aziza will make a presentation, and then we can go to the session of questions.
Okay, good evening, everyone. My name is Azza Badr, and I'm the technical lead for CRVS, which is Civil Registration and Vital Statistics in WHO headquarters in Geneva. And I traveled 16 hours to deliver this 10-minute presentation today. So I hope it is well listened to, because the message that I want to deliver is that the curriculum of medical certification of death should be included into undergraduate medical education, like it was done in Rwanda. It's not difficult. And this is the reason we put Rwanda before the presentation of what medical certification of death is, to show you that we're not talking in the abstract. 77 countries in the world, actually more than 77. 77 countries in the world have very good civil registration and vital statistics systems, meaning systems of countries where they can produce good quality causes of death, which are very important for public health and decision making. Another 78 have systems, but the quality of causes of death are not so good, and only 77 countries have systems which are not functional. Causes of death. So before I go on, I just want to find out from you, because I'm going to take your assessment at the end of this presentation of whether I made the message or the message came across or not. So how many of you today are still awake? I show of hands. Okay. Okay, good. So you're awake, good. Good. So I can start now making the presentation. So can you please put my presentation? Maybe. Okay, good. So this is about introducing the core competencies for ICD compliant medical certification of death into undergraduate medical education. And okay, why do we need to do that? Because we need comparable statistics by age and sex and causes of death, because it's also the Sustainable Development Goals. The three main purposes for medical certification of death are legal, statistical, and epidemiological. The legal, you understand, you need it to certify the occurrence of death, to find out if that death was natural or not, and for legal identity, the responsibility of the civil authority. Once a person is dead, they remove him from the population registered so that he cannot vote anymore, and his legal identity is no longer existing, and of course for inheritance. For statistical purposes, we get to calculate so many mortality indicators just by registering the death. And for epidemiological purposes, similar to what has happened in the COVID pandemic, we need to find out what people are dying from so that we can prevent death. We want to prevent death, and we cannot prevent death, but we can prevent premature mortality. Okay, so as I said, it's very important for determining levels and patterns of mortality in a country, establishing health priorities, assessing the health performance, the health system performance, and tracking national strategies, as well as measuring baseline and monitoring like the SDGs and so on. This morning, we heard a very important presentation about fine-tuning the curriculum of medical education to the epidemiological pattern of disease in the country. So how can anyone do fine-tuning of medical education to the pattern of diseases if we don't know that pattern? That pattern only comes out from proper death certification. Even surveys cannot give you the causes of death in a country. So there is no way you can find out what your people are dying from unless you do a complete system of medical certification of death. And again, the word certification was used today in 5 different ways. What we're talking about is not handing over the certificate of death to a person who dies. This is the responsibility of the Civil Registration Authority. And this is just a certificate that says this person has died. This is called a death registration certificate. And it's not about the accreditation or the certification that an hour ago was talked about. This is an old acronym or an old terminology that has been used by WHO for more than 60 years, and that's why we retain it. It is about completing the medical certificate of cause of death. And we call it certifying death. But actually that part, it has to do with the international form of certification of death, but not about handing a death certificate to the family of the deceased. Okay, so just let me give you an example of, this is just to illustrate one of the uses of mortality statistics. This is where you get the headlines in the newspapers. They get them from the compilation that is done by the Ministry of Health for the leading causes of death. Okay. And this is an example of how statistics are used. These are maternal mortality in the USA, England and Wales, and Sweden for 100 years. And because they were measuring maternal mortality, they were able to lower maternal mortality levels. Otherwise, it would have not been lowered. Another use is the measuring inequalities. This is the map of the United States. The red pockets have a life expectancy of 20 years less than the dark blue pockets. And mortality is the ultimate measure. It's a summary statistic. It's a summary statistic of what a person has been subjected to all his life. Socioeconomic inequalities, food inequalities, nutritional, lack of jobs, lack of education, all this reflects in the life expectancy. You find among the richer populations, people live longer. The poorer populations, people live less. So life expectancy is a summary statistic of inequalities. So it's very important. So what is this all about? I'm not talking about something complex. It's a one-pager, one page that the physician is required to complete. It is completed in exactly 5 minutes. And it's composed of 2 parts. Part A and what we call frame A and frame B. So frame A is this. It's just 4 lines that have A, B, C, D. The physician is requested to write 4 causes of death in sequence, meaning the direct cause of death is written on line A, and what is the direct cause of death due to, and the lowest used line is called the underlying cause of death. So what is the definition of a cause of death? A cause of death are all those diseases. This is a very important definition that WHO has developed in 1967, and it's still valid. All those diseases, morbid conditions, or injuries which either resulted in or contributed to death, and the circumstances of the accident or violence which produced such injuries. So this is the definition of a cause of death. This is what the physician is required to write on the death certificate. The other concept is the concept of the underlying cause of death. It is the disease or injury which initiated the train of morbid events leading directly to death, or the circumstances of the accident or violence which produced the fatal injury. This is what we're interested in. Any physician, even the forensic medicine physician, the legal medicine physicians, the pathologists, when they report the causes of death, they always quote the direct cause of death. We're not interested in the direct cause of death. We're interested in the underlying cause of death for public health and prevention. So it is the underlying cause of death that we would need to prevent so that the disease does not progress, so that we don't have to treat the patient during his lifetime until he dies from that disease. For example, a person dies from pneumonia, this is the direct cause of death. We call that an ill-defined condition. And statistically, we call it a garbage code. It is absolutely not essential for public health intervention. What we need to know is that this person 20 years ago had diabetes, and then it evolved and so on and so forth, and he got diabetic foot, he went to the hospital, he died in the hospital of pneumonia. So we need to find out the diabetes, and this single cause becomes the cause that becomes tabulated in the mortality statistics and the causes of death. Okay, so the rest is easy. Frame B is the manner of death, whether a person has died from disease or an external cause. External cause is suicide, homicide, or suicide, which is self-inflicted, homicide, or accidental. Okay, and then there's another section related to the place of occurrence of the external death, external cause. Where did it happen? In the street or at home or in the hospital or whatever. And then a section regarding fetal or infant death to determine whether this was a real a real live birth that died, or was it a fetal death. And then a section related to maternal death. Very few tick boxes that he just has to tick. The only thing that he writes in is the one which has the causes of death. Then, I'll give you an example. So, in the room today, how many physicians are in the room today? Can I have a show of hands? Okay. Very few. All right. Very good. This is good enough, but this example will be easy to understand even if you're not a physician. So, a 50-year-old woman was admitted to the hospital, and she dies from esophageal varices. So I can't see the example, okay? And the investigations revealed portal hypertension. Portal hypertension is the hypertension of the portal vein, which is in the liver somewhere. So the woman had a history of hepatitis B infection. So 3 days later, she dies. Now, the physicians in this room, please tell me, what would I write for the cause of death of this woman? Can I have just a show of hand? How, if you're the physician treating this person, how would you write the cause of death of this person? Esophageal varices. She had the bleeding esophageal varices due to liver cirrhosis, due to hepatitis B infection some 20 years ago. So what is the underlying cause of death? What is it that led this person to death in their final stages? Anybody except Dr. Yusuf? Go ahead. Can you just do this? No. Another? No. Okay, go ahead. Okay, use the microphone.
I would put first the immediate cause of death as bleeding esophageal varices due to portal hypertension due to liver cirrhosis due to hepatitis B. So the underlying is hepatitis B infection.
Excellent. Please give her a hand. So, yeah, okay. The secret word here is that she's a pathologist, but even pathologists normally don't know how to write the causes of death. So, excellent. The cause of death is hepatitis B. So this is what we want to prevent, so that this person does not need to die 20 years after. We need to prevent it 20 years earlier. So the sequence will be as follows in the death certificate, exactly as same as the professor mentioned. It is hepatitis B leading to portal hypertension, and then leading to bleeding esophageal varices. The direct cause of death is the bleeding esophageal varices, and so on and so forth, until we get to the underlying cause of death, which is the hepatitis B. Okay? Very good. So let me just give you a flavor of what mortality statistics look like globally. The average death registration globally is 70%, with the Afro region, which is Africa, except North Africa, is 15% death registration, and the quality of the causes of death is 4%. So we know the causes of death for only 4% of all deaths that take place in Africa. So just can't seem to get this working. Can somebody move it from your side? Okay, and this is what the map of the world looks like when it comes to death quality of causes of death. So the whole of Africa, by the way, is gray. Means we don't even have information, except for those red places, and those red places are the ones with good registration of death, but low quality of causes of death. Okay, this is what Kenya looks like. For the data that we have, of course, we don't have causes of death for the whole of Kenya, only for a fraction. So the registration, neither the registration nor the certification of death is 100%. It is very, Madam Janet Mishuru is the head of the civil registration services in Kenya, and she will give you a short synopsis on what it looks like in Kenya in the panel discussion. But these are the causes. The causes, most of them, except for malaria, even tuberculosis is not sure. Except for malaria, these are all what we call garbage causes of death. Pneumonia is garbage, sudden death, cardiopulmonary arrest. Tuberculosis, if it's due to HIV, is also garbage, because we don't know if this person had HIV and that's why he developed tuberculosis, or it was a real tuberculosis. And so the codes also have to be there. So this one we've already done. Can we go ahead? Okay, so now this is the reason we need to do MCCOD training. WHO usually does that, but it does it for in-service. What we're trying, and it's like continuous and it never ends. Whoever we train leaves and goes somewhere else, and so on and so forth. So we need to start from the medical education. This will produce high quality statistics, and at the same time with higher efficiency. We don't have to do ongoing and continuous training. Yeah, exactly, for the causes of death. And so this is basically the last slide. So we need to integrate death certification in existing curricula. Where to integrate it, this is your game, it's not mine. But basically, it's 3.5 hours of lectures, only 3.5 hours of lectures, and 2.5 hours of practical. And that's it. So that's it from my side. I just now need a show of hands showing how many of you got the message? Excellent. Thank you so much. Thank you.
Another round of applause for Aziza. I think we will have a question and answer right now. So we will be having questions and answer. Is that Dr. Wangari? Or, oh, okay, sorry. There are a number of colleagues who have come to assist Dr. Aziza from the global statistics in the WHO, and they will be helping her in answering some of the questions that will be asked. And then we have Dr. Tadi from Rwanda, who will be also answering questions from the presentation that he made. And so given that there were 4 areas of causes of death, I will give 4 questions. Because I think he's part of the group. So, can I see by show of hands so that we all have the people who want to ask questions? So we have 1, 2, 3. Can we go beginning from the back?
So good afternoon. My question is, in situations where it is not specified whether it is immediate cause of death or underlying cause of death, where mortality data is just captured. So what is usually that element that is picked? Is it the immediate cause of death or underlying cause of death? Because even in our statistics here in Kenya, in our DHIS, the records information system that we have in Kenya, we usually capture cause of death, but it's not usually specified whether it is underlying. So which one should we pick for the purposes of documentation and records? Thank you.
Did you get that?
Yes. Yeah. Also, I look at it. An excellent question. This is what we meet in when physicians write death certificates and they are not trained. Then we have created rules for the selection of underlying cause of death. These rules are found in Volume 2 of ICD 10. It's the rules and the guidelines. They are quite complex, but we have now developed a simpler form of these rules. So we have what we call 26 selection rules. When the physician has not properly completed the death certificate, the statisticians or the coders or the health information management operators, they use these rules to reselect the underlying cause of death. And maybe Dr. Soti wants to comment as well.
Thank you. Dr. Soti is my name, from Ministry of Health, Office of the Director General. I'm also a focal point in the Ministry of Health for Bloomberg Data for Health Initiative. And I have before been a head of M&E where DHIS2 is, and we have trained before. So what finally goes, just to be direct to the answer to your question, What finally goes as cause of death is the underlying cause of death, because that is what is supposed to be picked as presented by us. That is what makes sense when you talk about the cause of death, not those other items. So when you see a cause of death in DHIS 2, that is what is picked as underlying. Of course, we know that there are issues with that data because they pick it from the document that was shared, the certificate. So if it is wrong in the certificate, it is also wrong in the DHIS. Thank you.
Thank you. So at least the gentleman behind, Professor Ogena.
Thank you, Mr. Chairman. Thank you, Dr. Aza. The statistics are interesting here on how poorly we are doing in Africa. I noticed that the definition of death was done by WHO in 1967. That is 55 years ago. The Universal Declaration for Bioethics in 2005 has raised issues as to exactly what's death. One, there are cultures that preserve human body and believe their people are not dead. Two, human rights has come up and they argue that if death is legal because the brain is not functioning, what about organ harvesting? What do we say? So these issues are arising and challenging the death definition of 1967, and the human rights activists are now becoming very strong in arguing that death is relative. Now, among the Christian community, they don't believe people die. They believe the spirit lives on. That is a third context of death. Your comments, Dr. Aza.
Yeah.
Thank you for that question. I don't know whether any of Aza's colleagues understood so that they can...
Actually, I have no comments if anyone can say, but he is very correct. But this is the definition of death. What we gave now was the definition of causes of death.
Speak close to the speaker. Dr. Aza, just speak close to the speaker so that we hear.
What the gentleman was speaking about was the definition of death. But the definition that we gave here today was the definition for the causes of death. So you are very correct. And that part is really still very kind of not settled on the actual definition of death. But the causes of death, that is settled. And it's just for the purpose of writing the death certificate. After we have established that this person has clinically died, then we need to establish also what he died from.
Yeah, so I think you want to contribute? Yeah.
Yeah, thank you very much. I want to echo what Azaz said, but also reinforce that by saying the definitions about cause of death are also enshrined within the constitutions in a country. And I think our civil registrar ministers can actually give us more specifications on what law defines how we report causes of death, and I will pass that to her. Thank you.
Thank you. Maybe what I would like to do, in Kenya we are doing very badly in registration of death, and sometimes we wonder why, because it's compulsory for one to, before they are buried, for a death certificate to be issued. But what we are seeing in our offices, despite death registration being compulsory, we see forms which are left blank, and we are unable to have completeness in death registration with those kind of forms. We derive our mandate of death registration from Cap 149, and it's actually criminal for those forms not to be filled properly. And the Constitution, we also work under the Constitution, Section 3, and we need to make sure that the forms on death registration are properly filled. That is D1s. We make sure that we provide D1s to the health practitioners so that they make sure they take the time to fill them up. Otherwise, it's causing concern because we can't have complete death registration without those proper reporting.
Thank you. So I think there is definition of death that they are saying is not very clear for now, but causes of death is very clear. Professor Ogena.
Thank you, Mr. Chairman. I was just trying to draft in case I forget what I wanted to ask. And I really want to thank Aziza for that very well put presentation. And I want to tell the group that is sitting here that actually we are training doctors. This is in our curriculum. I have taught in the University of Nairobi, and we have the content. What I don't know is the attitude. Could it be an attitude problem? Could it be lack of supervision? And could it be also that there are so many people involved in death notification? We did a study in 2014. It's actually on, it's a free access paper, quality of cause of death statements in Kenya. And what we noticed was the causes of death that were written by pathologists at the city mortuary, the quality was good, between 80 and 90% quality. However, the causes of death that were written at a training institution, which was KNH, where the University of Nairobi practices, and we did that study while I was working at the University of Nairobi, the quality was ranging from 40 to 30%, just depending on what disease we were dealing with. And what our thought was, it is likely because there are so many people involved in the chain, including interns, clinical officers, the junior most medical officer, writing these causes of death. And number two, that the quality will depend on the type of disease. Why? Because we think that with KNH or UON, a lot of our patients die before we actually make a correct cause of death, identification or diagnosis. So we fear to look at it objectively, look at all the data and give. Now, what I would want to ask is, wonder this for, because I think number one is the form to be locked in, and number two, supervision. I think Ojuka, Stephen Ogendo, who's in here, let's take those responsibilities seriously. And the interns are not rotating in departments that would supervise this. For example, in pathology. Thank you.
Thank you, Prof, for that good question. Do you want to answer?
Yes. Thank you very much, Professor, because you said it very well. You were asking herself whether it is attitude or lack of knowledge or lack of supervision. So she asked how now we come up that the form was accessible to all physicians, and how. So first of all, there were two issues. As we said, there was lack of sufficient knowledge on how to fill it properly, and then the intervention was to conduct cascade trainings from face-to-face up to online. That was number one. Number two, now was to sensitize medical doctors, physicians, to appropriately determine the real cause of death by filling the form. Because there was a kind of negligence. They feel the way they want. They just say cardiac arrest in bad handwriting. So, and everybody knows that when there is a death, of course, cardiac is not the cardiac is arrested. No oxygen in the body. So that was number two was done now to try to sensitize medical doctors to take their time to establish chronological events of conditions. And then number three, as the intervention, it was to make sure they have skills and they make sure they complete appropriately. This form was among the checklist to verify during a medical malpractice investigation process. When there is a malpractice is composed by either there is an injury or there is a death. When there is a death in hospital A, that case is immediately reported to medical council. Medical council establish a team of experts to go on the ground and do a serious investigation to establish facts. And then when they go there, they ask first of all who participated in the treatment of these patients. They come. Number one, show us your license to make sure they are licensed to practice in that scope. Number two, they say, present us the patient's file. And in the patient's file, they should check whether there is MCOD certificate. And then when it is badly filled or there's ignorance in filling the form, so the doctor will be accountable. So now, as they know that any single death is audited, any single death is investigated, they try now to fill the form appropriately. And the form is available on the website.
Thank you. I think this now that there are only 3 questions, I have my question that goes to the team that is over here, together with Professor Ogena. But I hope one person could answer it. What would be the policy statement that you would probably want to think from what has been said in this podium and in this hall with regard to filling in that form? Dr. Aza?
Sorry, I didn't get the question. So is it about the quality of the mortality statistics?
What is the policy?
Policy. From
the discussion. What is the policy statement?
What would you think would be the policy statement that would come from what you have presented together with the discussions that we have had?
Thank you so much. So in summary, what we're saying is that WHO and Vital Strategies and UNECA and the ministries of health of each country, they do in-service training for physicians for certification of death so that they have high quality mortality statistics. What we are recommending is that all countries in the African continent and globally integrate the competency of how to complete what is called ICD compliant medical certification of death into undergraduate medical education in order to improve the quality of causes of death. As mentioned by the professor here, it is not only about filling the certificate. There are like about 5-6 steps more that take place after the filling of the certificate. One of it is the validation. One of it is the selection of the underlying cause of death. We need to remove the implausible causes of death. Like, for example, a man dies from, for example, breast cancer. Even though men can die from breast cancer, but for something, or a man dies from pregnancy-related issues. So the cleansing process of the mortality statistics, and then the tabulation, and so many other, and then the analysis of the causes of death, and then to prepare policy briefs from that is very important. Because many times the countries do have good quality causes of death and they don't use them for policy making. And also to add to what the professor said is that most hospitals have what they call mortality audits. So this is a good a mechanism for improving the quality of causes of death. Through these mortality audits, they can go and review the medical death certificate, even if it has already gone out. So for statistical purposes, they can revisit the death certificate and then produce correct statistics.
Thank you, Dr. Aza. I think our colleague from UNECA, what would be your perspective?
Okay, thank you very much. And I'll begin by responding to Professor who was talking about issues around implementation. So in the region, UNECA is supporting the rollout of a framework for assessing the business processes. I agree with you when you mentioned that there are so many people involved, and so sometimes that is where the loopholes are. So we've introduced, together with our partners right here in front, we have introduced the business process improvement framework, where we are looking at the steps and each business process and identifying the bottlenecks that could be causing or resulting in poor articulation of causes of death. So my recommendation, and I think it's a recommendation from all of us, is that each country we go back and we try to see where are we losing the data, where are we losing the right information. Then through identifying those bottlenecks, we identify our priorities, the low-lying fruits, and those then become our quick wins for our policy and strategies. Thank you.
Thank you. Dr. James, 1 minute.
Yes, I want to answer Prof. The policy statement. Medical certification is part of good clinical practice, and doctors should be facilitated with opportunities to get skills on that area of work, and it should be regulated like any other aspect of clinical practice. Thank you.
All right. Facilitation and regulation. I want to thank you, all of you. Let's give them a hand of applause for that presentation and discussion. We appreciate the knowledge that we've got. And as James says, I think we will be thinking about how that facilitation should be and how that regulation should be done. I thank you. And I thank all of you for listening to us. I am told that there was a video that was missed, the video of Daniela Njeri Munene. That is the nexus between training and practice of pharmacy, adapting to health system requirements. So as these colleagues go to sit, those who will be available will be watching that video. I thank you.
Conference of Repositioning Today's Health Workforce for the Future. My name is Dr. Daniela Munene. I am a member of the Executive Committee of the Pharmaceutical Society of Kenya, and I am a Director of Kenya Healthcare Federation as well as Head of Operations at Africa Health Business. Today I'm pleased to get a few minutes to share with you my thoughts on the nexus between policy, training and practice, and how we can adapt to emerging health system requirements. My presentation will go as follows. I'll make a brief introduction. I'll talk about emerging health system requirements. Then we'll look at aligning policy, training, and practice and what that takes. And then I'll make a few recommendations for your consideration to take out of this conference. So, by way of introduction, let's talk about the elements of our profession. Professionals require specialized training and lifelong learning, and they exist to discharge a social contract to the society in order to alleviate suffering and bring solutions to their most pressing problems. So what about us as healthcare professionals? We are trained to alleviate illness and promote health. Ernest Greenwood, who is considered to be an expert in the field of professions, proposes that a profession must have the following elements. 1, a systematic body of theory or knowledge. 2, authority and credibility. 3, community sanction, the so-called social contract. 4, a code of ethics. by which all professionals must follow. 5, a professional culture, which is exemplified by values, norms, and symbols. To the left of my screen, you see various logos of health professional associations. I just picked a few. And if you look, you'll see a recurrent theme of symbols.